Hey people, how are you doing? My name is Matt Phillips, creator of RunChatLive.com, and this is episode 172 of the Sports Therapy Association podcast, recorded normally at 8 o'clock live every Tuesday on the Sports Therapy Association YouTube channel, but tonight it's being recorded on a Wednesday because obviously yesterday everybody, including our guest, was trick-or-treating. And good fun it was as well. So some housekeeping first of all. There has been over the last 2 or 3 weeks, sounds like I'm going to do the news now. It's not that dramatic at all. Over the last 3 weeks, there has been reports of problems with the YouTube. Okay, so if you are listening to the live stream on YouTube and it does crash again, then just head over to Facebook, either the Sports Therapy Association open group or the Sports Therapy Association Facebook page, where it works fine. Okay, just warning you if it does suddenly cut out. Although having said that, I did manage to record a Run Chat Live podcast episode yesterday about my gait analysis presentations at this year's Therapy Expo, and that kind of went fine. So hopefully, touch wood, YouTube and Belive software is working okay now. Also, if you are joining us via the Facebook open group and you want to add comments or questions, so if you're in the group, then you do need to click on the post that I put in the comments, which is just where you click on a website which gives Facebook permission to put up your comments on the Belive software as well. If you're looking for that link because you can't see your logo or name, then just look in the comments, or what I'll do is I'll bring it up here on the screen as well. If you are looking watching YouTube or on the videos, then I will add it to the screen now for you. So anyway, there we go. We are continuing our countdown to Therapy Expo 2023, which is happening at the NEC Birmingham this November, 22nd and 23rd. So not long away at all now, like a couple of weeks we're talking. No, 3 weeks. Yeah, 3 weeks. Bringing you in these podcast episodes, speakers who are going to be presenting in the STA Update Theatre. Last week in episode 171, my guest was the fantastic Sonia Fierro, who joined me to discuss her presentation that is going to be happening. Well, she's got quite a lot going on at Therapy Expo, but she's going to be in the STA Update Theatre on the Wednesday, so day one, as part of the Women in Sports Therapy panel, which is at 2:30 p.m., which I totally recommend everybody comes along to. It's just so inspirational to see. There'll be herself, there'll be Anna Maria from last year, there'll also be Michelle Lyons, Women's Physiotherapy, and also number 4, obviously, Dr. Fiona Higgs is the host of the Women in Sports Therapy podcast. So that's on the Wednesday. And then Sonia Fierro will also be in the STA Update Theatre on the Thursday at 11:30, talking about what she talked about last week, which is functional flexibility, which is such a great episode. She's so clued up with flexibility, and she's a classic example of not being tempted to jump to one of the black or white sides. As always, kind of, not always, it's a fallacy to believe that the middle is always perfect, but within therapy, because we know so little about how humans work, often that middle area is kind of a place we should be hanging out. As soon as we get too definite either way, then we're probably making a little bit of assumptions or mistakes. So yeah, great episode with Sonia Fierro. Thank you so much for joining us if you're listening, Sonia, especially as you were with your little Babs, 18 months or something now, I think, who was doing their best to keep you away from me. Also, if you do want to follow Sonia, then I'd highly recommend, I think I got her Instagram account wrong when I was speaking because I was just trying to pacify the baby at the same time through the screen. The Instagram account is sonia.recoverstronger. So that's Sonia, SONIA .recoverstronger, all one word. I do recommend you check it out. Right then, I did warn my guest tonight he was going to be down in the lobby for quite a while, but he's got something to do down there, which is fine. So tonight, my guest is Alistair Beverley of theldphysio.com, who's going to be discussing his up-and-coming presentation, Keeping Your Hair On, What You Weren't Taught About Communication. That's going to be happening in the STA Update Theatre at Therapy Expo on day 2, which is the Thursday at 12:15 p.m. Alistair was on the show back in February. I don't know where that time all went, with an episode called Healthcare for People with Learning Disabilities, which is what the LD and the ldphysio.com stands for. Massively, hugely insightful episode, which we will touch on as we start this episode. But rather than me talk about it, we're going to bring up the man himself, and we'll link that episode to what he's going to be presenting at Therapy Expo in November. So without further ado, I shall bring up Alistair Beverley of the ldphysio.com. Hey, Alistair, how are you doing?
Hey, Mark, very well, thank you. Thanks for having me here.
Oh, no, absolute pleasure. Thank you for giving up your time, especially as people who are listening to the podcast you can't see, but here is a man who has worked out and is just oozing those endorphins. You can see. I'm not saying you're sitting there hot and sweaty, but you can see you're looking wide-eyed and
It's smug face. It's post-exercise smug face. That's all it is.
So, how's life, man? It's good. I haven't seen you since. Well, no, I don't think I've spoken to you not face to face, as it were, since February. So, how's things? How are
No,
things?
really good, really good. Business is increasing. I think as the name of the business is getting out there, we've managed to take on a therapy assistant. My wife Liz has quit the rat race and is a bit of an expert in this area of field of people with learning disabilities anyway. And so we're just doing the training up on the therapy assistant side of things. And she's up and running with her own little caseload now.
Wow.
We've got some new contracts in with a local, I say local, it's an hour and a half away, but it's in Rotherham, a local further education college for people with learning disabilities, providing the physio input there. It's all quite busy at the moment, obviously speaking to you, we've got Therapy Expo coming up, a couple of new physiotherapy students, working with universities as well. Again, just trying to get the message out there, the same message that we played there in February, about the needs of people with learning disabilities. So it's busy, but it's enjoyable. I'm also refreshed, extra smug face, because I've just come back from a week on holiday, which is a bit of a luxury when you're self-employed, but we decided to take a week away in Spain. So extra tanned smug face, I think would be the best way to put it tonight, Matt.
You deserve it. You deserve all the holiday you can get. I did enjoy. Was it you who went away, or was it? Is it, what's the name of is it Friday Confessions or Physio Confessions?
Oh,
yeah. Martin. Was it you went to him or he came to you? I can't remember. With the sunglasses.
He came to me. Yeah, he came to me.
That was fun following that. That was interesting,
yeah.
No? It looked like you were just all taking the piss out of each other, but I gather there was some kind of sharing of practice as well.
There was some sharing of practice in amongst the alcohol and the laddish behaviour. But no, it was really interesting. And Martin does work with people with disabilities. As well. Was a bit of a generic island physiotherapist, as he put it. He now works specifically with children with disabilities, so there's lots of carryover there in terms of our work. And Martin brought some really good ideas, some stuff that I'm going to take forward, and I might have learned one or two things, but don't tell him those things because I don't want his head to swell.
Exactly.
It needs to.
Yeah. He does sing quite cocksure, I think, is the English word, which you might need to look up. But you definitely get a T-shirt with that one. So I'm just going to say now, people, because it's definitely for so many reasons worth following you. So Twitter, you're at the LD Physio, easy.
Yep.
Instagram, it's at _ the LD Physio _ because there's a few LD physios. I guess if your name's Len Dunstable or something, then that's it, isn't it? You're gone.
That might have also been an admin error on my part when I created an account and forgot the password. Instagram wouldn't let me recover it.
I know how that feels. Yes.
I mean, yes, somebody else stole it before me. That's what it was.
Yeah, that's it. So yeah, Instagram at _ the LD Physio _ and then email. I won't say it, private email, but then there's the website as well, which we'll talk about shortly. But anyway, so yeah, we first met. I had the pleasure of meeting you at Therapy Expo a year ago, pretty much.
Yeah,
so that flew by.
It was.
And I think probably if I say the name of the presentation you were doing there, that probably, if you explain that, it'll kind of open up pretty much, what back then the message, and still is, I imagine, the goal of LD Physio was all about. So it was an incredible presentation about a topic which I think very few people I was talking about and asking people were even aware of. They definitely didn't know it by its name. And so it was diagnostic overshadowing, when the correct diagnosis can kill. So maybe if you could start letting people know what that is all about, and then how that ties in with ldphysio.com.
Yeah, so diagnostic overshadowing is, it's a clickbait title about when the correct diagnosis can kill, but it's not necessarily too far away from the truth. Diagnostic overshadowing is the concept of when you have somebody who has a specific diagnosis, and in the cases of the people with whom I work, that tends to take the form of a learning or intellectual disability. For reference, those two terms are interchangeable. It just depends what country you're in. But diagnostic overshadowing is when you put down all the clinical symptoms that somebody may be presenting with to the fact that they have that disability. And that might take the form of, you see somebody with learning disability who has limited communication, who starts to bang their head against a wall. And they might present to you in clinic, and you go, well, they're autistic, they've got a learning disability, that's just what they do. and you don't investigate any further than that, because on the surface level you go, well, they're autistic people sometimes do these sorts of things, crack on. And you might miss tooth decay, severe 𝐊𝐸𝐼𝐶 headaches, and a host of other potentially serious things, or even minor things that could be going on there, but that could be sorted. And there's some more examples, and one that's a little bit close to heart was my brother John, where John had a hernia and presented with acute hernia pain, and it was not treated on 4 separate occasions, and it presented with all the symptoms of a strangulated hernia, and my brother died from a hernia because his pain presentation was put down to the fact that, he's got Down syndrome, they don't deal with pain very well, so let's just give him pain meds. Whereas if you or I presented to hospital, laid on the floor screaming, and with acute vomiting, we would have been probably seen through clinical guidelines much more quickly. But it was, he's worked himself into a bit of a tiz with his pain, let's give him some painkillers and let's send him off, and then drug him up, and then he goes home. And then the talk, Diagnostic Overshadowing, that I did last year, I talked about my brother, probably for the first time in full. I've mentioned it on a couple of podcasts. John did pass away in 2020, I think it was, on my daughter's 6th birthday. And I knew about advocating for people with learning disabilities. My family knew about what we need to do when somebody goes to hospital. And yet my brother still died from a hernia. And so that's where that talk kind of came from, is to say, actually, if we can make healthcare professionals more aware of this as a concept, we can almost check our bias, for want of a better phrase, in the same way that somebody might come in with pins and needles and you say, okay, maybe that's a yellow flag pathology. Maybe we just need to bear that in mind for future reference. And then anything else that comes up, we'll investigate that a bit further. What I'd like to see is learning disability almost considered like a yellow flag pathology. In so much as if somebody has a learning or intellectual disability or a difficulty communicating their thoughts and wants, then we flag that up in our minds, and then we almost overthink our future clinical reasoning, regardless of that. If the person didn't have those things, how would we proceed? And how do those things play into the person that's in front of us? Because all too often, and there are a myriad of cases, about 50% of people with learning disabilities who die each year die from preventable healthcare conditions. My brother was one of them. And so introducing this concept of diagnostic overshadowing, which you, Matt, listeners, and almost everybody that I've met hasn't come across, which is fair. That's why people haven't been taught it. Is something that is so important that we get across. And one of the things we talk about how things have evolved, if I can move it on, is last year we were looking at, and in February we looked at treating people with learning disabilities. What I want to do now is look at how taking concepts from supporting people with learning disabilities, how can that impact on mainstream healthcare? And in reflection, I've thought that diagnostic overshadowing isn't just something that affects people with learning disabilities. It's applicable to elderly care. If you've got somebody who's got dementia, and then maybe, Irene in B5, bed B5 starts crying out in the night, do we just go, well, she's wailing, she's got dementia? Or do we say, well, maybe something's happened, she might have a spontaneous hip fracture or something like that? We could be missing these things for days, even weeks, because we don't take people's clinical presentations seriously, because the overarching diagnosis is the thing that clouds our judgment. And that's diagnostic overshadowing.
That's your point about comparing that to somebody who maybe is old, and you think, oh, they're just old, and this is amazing. It can happen. I was thinking, as you said that, I thought other end of the coin, what about kids? I was thinking, yeah, with kids, sometimes they're in there, and I know cases of where they've been kind of like complaining of pain around their feet, or they've been sitting there kind of waggling their legs, and you're thinking, oh, they're just nervous, or they're because with their parents, and you're missing diagnosis because you're thinking, oh, it's just because they're a kid, they're embarrassed, they want to get out of here, and it's great. And I guess that's what one of the big ideas of your theme at Therapy Expo this year is. Let's just read out the title again so people can recap and then make the segue themselves. So this year at Therapy Expo, just to repeat in case you jumped in late, Alistair Beverley is going to be talking to us about keeping your hair on. Nice metaphor. What you weren't taught about communication. That's going to be on the day 2 at 12:15 p.m. in the STA Theatre. So yes, Tell me about that title, and that's essentially what you've been talking about, yeah? How it can...
Yeah, completely. And that's where we're looking to move. You know, my area is a niche area of practice, and one of the challenges, as we mentioned before we went on air, is about, you know, almost getting people through the door, over the threshold of engaging with this sort of topic, because it almost becomes a self-fulfilling prophecy. Learning disabilities is a niche area that shouldn't necessarily be a niche area. My ultimate job role is to do myself out of a job so that I'm not needed as a specialist. That's my ultimate, you know, long-term goal that will never happen, but it's fine, because people's needs should be met through mainstream healthcare services. But how many mainstream healthcare services are geared up to support people with learning disabilities? So I started off by trying to change mainstream healthcare services with some success, and that's still definitely part of my ultimate goal. But to get people through the door, because people thought, well, somebody has a learning disability, that's not my area of practice, so I don't need to listen to this. That then reinforces the self-fulfilling prophecy that people with learning disabilities have poor healthcare, because mainstream or the specialists in that area don't engage with people with learning disabilities. So what we've tried to do this year, what I've tried to really focus on, is changing tact a little bit and going, actually, there are a lot of really important messages and lessons and teaching points that mainstream practitioners can take from listening to people who support people with learning and intellectual disabilities. You know, I teach this at university, we run courses on it, but really trying to focus on that. So one of the things, you know, we talk about is communication. And I think universities and undergraduate education across healthcare are getting better at communication. We probably had an hour and a half lecture on it back in the dinosaur days, when I was at university. But I think there needs to be much more emphasis on that across the spectrum, and not just made like this is a lecture on communication. We need to embed communication as part of what good healthcare practitioners, what a good healthcare career and training looks like. And when it comes to communication, we talk about open-ended questions. We might be talking about how to support people when the going's good. You know, you ask a question in a subjective, someone gives you an answer. How do you interpret that answer? How does that affect your thinking? How do things move forward? This all is great until you come into a situation where either, number one, the person doesn't understand your question or cannot answer, which is almost what some of my patients and people that I support can't do. So our communication falls down there. Or also if you've got somebody who doesn't want to engage or doesn't want to answer, or maybe slightly miffed off with the situation that they're in, or potential healthcare services that have been provided to them in the past. And so as somebody works with people who don't necessarily always, and not all of them, but always understand what you're doing or why you're doing them, I come across people who may be less than willing to engage within physiotherapy services, probably more often than most, but not all therapists. And I think from that, there are some interesting points that we can look at when it comes to dealing with people who are upset, aggressive, potentially also maybe not necessarily making a lot of sense in their upsetness, and how I've dealt with that over the years, and how listening and speaking to colleagues and as part of MDTs in the NHS and private sector and also internationally with Special Olympics, some lessons that we've taken from that. And I'm happy to go into them if you want, Matt.
Oh, for sure. No, definitely.
Yeah. So, I mean, I'll give you an example of somebody who's not necessarily making the most sense. So this is an example that came from a podcast that I was listening to, and I thought this was a great example for how to get somebody on board. One of the things with communication, I think that we struggle with as practitioners is getting people on board. We don't not necessarily the best at building that clinical rapport. And we know that building a clinical rapport is almost as important as a treatment methodology that you choose to use to gain an outcome. And we know that the better your rapport with the patient or the person that you're supporting, the increased likelihood of a positive outcome in the long term. And when somebody's shouting at you or not making much sense, it can seem a little bit odd in sort of how do you get that person on board. So I'll start off with that side of things. And this great example was by a psychiatrist who was working in America, and a very eminent psychiatrist. I'll not say his name, but it was on a podcast, and I can't remember the link to that. I apologize. And he said he had this patient who came in for a psychiatric session, and he came in and was banging the table. I'm not going to bang because I'm going to obviously it won't make much sense to people, but yeah, banging the table very hard and saying, I've just seen John the Baptist. I've just seen John the Baptist, and I went to the church to tell them, and they threw me out, and it's part of a conspiracy, and nobody believes me, and nobody wants me to sell the message. John the Baptist had a message for mankind, and nobody wants to hear it. And I think that you're going to be part of it as well. And this psychiatrist was like, okay, clearly you've not been taking your medication. And so his first opening question for that was, have you taken your medication? Which then added fuel to the fire of this person's agitation at that point in time. During this session, this psychiatrist had also had a student across from the UK. And the psychiatrist had tried a few sessions without much luck. And I got to the point of going, well, I don't know what to do. And he sort of put upon the student, he gave the student quite a big promotion. He said, I've got this eminent professor across from the UK. And the student sort of bristled in the corner like, what? I'm a student. I'm just here to observe. This eminent professor from the UK. I wonder what his take on this is. And the student reflects on the point that they were absolutely papping themselves at this point. I had to think very quickly on their feet. And what the student said is, where I'm from in England, I was brought up in quite a religious community. And so if John the Baptist has a message for mankind, I'd like to know what he had to say. And all of a sudden, the person just deflated. All the hot air and steam went out of them, and they were like, somebody is listening to me. Somebody is believing me, and somebody wants to hear my story. And so he told this person all about the message that John the Baptist had, and he chatted away to this student from the UK for about 45 minutes. At the end of the session, he turns to the psychiatrist, shook his hand, and was like, thank you, doctor. That's the best session I've ever had, and I'll see you next week. Don't forget where I'll take my medication. Thank you very much, and left. And he said, I had to digest this session. And I was like, what happened there? He had no idea. And it was only through reflection and afterwards, he said, well, what you did actually is you didn't become part of the problem. You used joining language. He was saying, I've got a message, for John the Baptist. Well, what is that? You're clearly in a situation where you are being told, no, 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 no. And that's a point of agitation for you. What is it that you want to say? And in a clinical setting, that's really important because a lot of people, if they are upset, they will be upset for a reason. So there's almost an element of when people are upset with you is weathering the storm and saying, look, I can see that something's bothering you. Would you like to tell me what that is? How can we help you? And almost just sitting there and letting people get it off their chest. And then what he did is it was like, I hear what you're saying. I hear what you're saying about John the Baptist. Could you tell me a little bit more? So again, open-ended questions, and then help to frame the narrative of, I believe you. I believe that there is some truth in your experience. He's not saying, I believe that happened, but I believe that you believe that. But he wasn't necessarily, so it's not a case of being false with it, but he was trying to, again, using words that help get the person on side, that joining language. And the psychiatrist, the student also said, I feel that if this happened to you, it must make you feel like, so he used I feel language. So he clarified his understanding, used joining language, used I feel statements. I feel that you're saying this and that must be quite stressful for you. And again, all this time you're putting yourself on the side of the person. And it's okay to say in a clinical setting, to say, if somebody's upset or has had a bad experience, to say, yeah, that sounds pretty shit. Excuse me, I don't know if swearing's allowed on this.
It's fine, you go for it.
But it's okay. I'm really sorry to hear that. You must have had a really shit time, or getting that diagnosis or living with that pain must have been terrible. It must have been terrible. Or that it sounds like you didn't have the greatest treatment experience. Classically, well, people will come to us and, probably the same in sports therapy and go, my last therapist just gave me some exercises. And that was it, and sent me away. Whereas actually, that's probably not what happened, but the therapist wasn't very good at clarifying the person's understanding. So he's going, oh, actually, I'm sorry that happened to you. That must have left you feel quite deflated and not supported. And then what we need to do is then put ourselves, not be part of the system. Because at that point in time, initially, we are part of the system, and the person is looking for the self-fulfilling prophecy that we will just treat them the same as everybody else. And how we sidestep that is we go, well, I'm here now. I want to work with you. What can I do right now that will help us and help you to get to a better place. And all of a sudden, you flip yourself from being the opposite side of the table, and you are then beside the person, helping move them forwards. And that can be, even if somebody says something ridiculous, I want an ice cream or whatever, how can that help? Well, we could joke about that. I'd love an ice cream too. Do you know what? Next time, maybe let's go meet around the shops. So again, you can use that and be flexible. But I don't necessarily think that we're taught to be flexible and think on our feet necessarily. We're taught this rigid, subjective, objective assessment, impression, range of movement. See you next week. Here's your exercises, off you go. And if we can be better at that and be better, particularly when people are annoyed, then healthcare will be a much nicer place for us, because it's not nice when you've got people who are upset, and it'll be a lot better outcomes for patients. Definitely. Does that make sense? I've ranted a lot there. Sorry.
No, it's beautiful. It's beautiful. And it should ring bells with people, listeners who have listened, for example. I can hear quite a lot of motivational interviewing in there, and how to basically, when you're trying to instigate behavior change, before if but I've got so many questions for you. It's brilliant. My head is just about to explode. But I'm wondering whether, like you said, we're very much still trained. Well, I'm saying we, particularly in sports massage, sports therapy, and probably similar in physiotherapy, although I just can't comment on that. We're still very much trained to be the operator, aren't we? To quote 𝐓𝐴𝐿 and Jacobs and that. We are the fixer, and we believe we've got the recipe, we've got the skills in our hands, or in the weights that we give, the right prescription of exercise to fix the person. So it sounds like what you're talking about is part to appreciate the importance of that. One of the hurdles you've got is to realize that what's going to fix this person is actually going to be you facilitating them and giving them the tools and the confidence and the behavior change with them. But it's, and I wonder whether both can be achieved by doing this, if people understand that communication actually is really important, because you've got to get that person, you've got to sit next to them, like you said, rather than just give them orders. Hugely important. And also, the other thing is business models, because I'm very much conscious of business models as well, particularly in Therapy Expo this year, because it's still a lot of people are leaving their career. A lot of people can't make ends meet. And not in all cases, but I think in a lot of cases, the I will fix you model is just not a very good business model, because they're not machines. If you want to do that, then great, become a mechanic where you can fix it, but with people you can't. And what you're saying to me sounds like this is a business model. This is where you are going to make a difference. Not all the time, because you can't, some people it's not going to work with. But so I don't know what you want to take away from that. Let's talk about, first of all, fixer versus facilitator. This is what you're talking about, isn't it? You've got to work with the person, not on them.
Yeah, no, certainly. And I think, that unfortunately there are still a good number of colleagues out there who like to apply, mechanical metaphors and similes to supporting people, and think that we are fixers. All the evidence says to the contrary. Almost all the evidence says it speaks to the contrary. And the person's lived experience is almost the biggest point. We know that long-term behavior change is the hardest thing for people. We know that adherence to long-term behavior change is the hardest thing. But this is something I think that would help with that, if I'm honest. But, if we don't employ these tactics at the very beginning, then there's going to be no behavior change whatsoever, because the person's not going to be listening to you or engaging with you, and you'll just become another part of the big machine who hates them and is part of a conspiracy, or is just another crap therapist. I think in terms of, you mentioned, about sports therapists, given this sort of rigid model, and I think it's not just sports therapy. And in my experience, it's not just physiotherapy. I think it's something that's across healthcare and rehabilitation. I have all the answers, and you don't. And in terms of that transition to the business model side of things, my whole business is built upon people for whom mainstream healthcare services don't work. Everybody that I see is entitled to NHS healthcare. Every single person. There's nobody that isn't. And yet they come to me, and some people have turned down NHS care because of, and this isn't because I'm great, but it's just saying, if you employ these tactics in your healthcare, and I work with people who've been let down, wronged, or feel like they've been wronged by mainstream healthcare services, and been able to say, oh, Joe, that sounds terrible. That sounds really, really bad. I'm really sorry that happened to you. Or I'm really sorry that you experienced those things. If you don't think somebody's actually telling the truth, I'm really sorry that's how you feel. Really sorry that's how you feel. That must be really bad. if that was me, I'd probably feel quite similar to you. What can we do now? What can we do to move forward? How can we make this situation that we're in? We can't change that situation, but how can we move forwards together? Excuse me, to make the future for you look better. So yeah, that collaborative model is certainly something that the evidence suggests as well. Gains better outcomes long term, and also improves patient relationships. And also, when we look at complaints, I was listening to a podcast with Jo Turner a few months back, and she was dealing with the complaints department of a big therapy rehab center, and she said about 85% of our complaints are because people don't feel like they've been listened to.
Mm-hmm.
They don't feel like they've been listened to. I came in and the therapist just gave me this, I had this sheet of exercises. They just chucked them to me. They didn't care. They didn't listen. And actually, if you can employ these tactics, that the amount of time that people will spend on complaints and disgruntlement with services will reduce significantly.
Mm-hmm.
So, does it help from a business model? Well, at the moment, it seems to be doing okay here. It's not the primary reason that we do it, but obviously, people have got to eat. And as somebody who's moved from NHS into private sector and now into private practice on my own, it certainly seems to be doing okay. There's plenty of people out there who are unhappy with the state of healthcare services, and that's a situation that I think is only getting worse as the NHS and rehab services across the board become more squeezed.
Definitely. I remember, I can't remember how long ago, but I'm sure I was speaking to a GP and they did say that there'd been like this input of empathy classes for GPs, and it might have just been because I was looking for it, but I did notice in the year after that kind of conversation that little things like doctors actually not being on their keyboard and looking at the screen while they talk to you, actually pointing to you, or not even being opposite you, kind of moving a little bit, just that physical, to get rid of that physical boundary and not being that typical higher up and lower down sort of thing, or choosing their words so carefully, not kind of allowing. They'd obviously been taught about catastrophization, how this can be a real thing, and I don't know, to this day I don't know whether it's confirmation bias or whether it's actually the result of some kind of good NHS strategy, but it is something which people do need to be taught, isn't it? And for a lot of people, it doesn't come naturally at all. It takes a lot of training. And that's something which obviously isn't given on therapy courses at all. It's like you say, there might be an hour, but people have to go out and get trained in it.
Yeah. They certainly do. And it's weird though, because we're dealing with people at, relative low points in their lives. As a sports therapist, you're dealing with people who are injured. And we know how much athletes are a pain in the arse when they can't train, and how mental health wise that suffers. And therefore people's fuses become shorter. And it just seems a little bit wild that we don't necessarily impart these skills on people across healthcare services. If you work in acute hospitals as a therapist, you're dealing with people during injuries. I'm dealing with people with learning disabilities, managing long-term conditions and neuro rehab services. So again, people whose lives have been turned upside down. It's fine for people to be angry, as long as they're not, threatening or dangerous to themselves or the environment or other people or you, and you feel safe. It's sometimes a useful space to let people have a vent. But our notion at the moment is, people can be upset with the situation. I'm all for saying to people, it's fine to be pissed off with the situation. It's fine to be, it sounds crap. I remember saying to one person with MS, they'd been diagnosed with MS for 2 years, and they were just telling me about the struggles. And I went, MS is shit, isn't it? And he burst into tears. And that wasn't employing any tactics. I was just sitting. I was like, this is crap, isn't it? You were, active, working, and now there's so many things that you can't do. I was like, that must be shit. And he said, nobody's ever said that. Nobody's empathized and gone. And he was like, and he came up with this tirade of swear words that I won't necessarily repeat now because HUPC and all that. And he said, I just feel like the first person who said, and I feel like you get me. Because it is shit. It is very, very bad. So yeah, for professions, both sports rehabbers and physios who are dealing with people at low points in their life, it is quite surprising to me that we're not necessarily imparted with these skills. I think our mental health colleagues potentially are, so particularly within healthcare. colleagues who support people with mental health issues may be imparted with these, but not the mainstream. And again, these are things that are coming from a niche area that I think could benefit mainstream clinicians. They're not infallible, though.
No, definitely not.
So I would remind everybody that I had an iPad thrown at me today and I was spat at by somebody with a learning disability who was expressing their desire for me to leave the room because they didn't want to do any physiotherapy. And so I took the message. But that was somebody necessarily that we wouldn't be able to engage in a verbal communication. And we're working on their ability to build up tolerance to being with new people. It's a new college year for this person. So, but you know, people can still be angry. And even with these skills, people can still be upset. And, you know, there's no place for us to take abuse. And there's, you know, so in that situation today, I left the room because clearly they didn't want me to be there. And I didn't want to have those things thrust upon me today. And so we left the situation there. So they're not infallible, but I think, you know, for the vast majority of patients who will be able to understand and respond to your questions and answers, they're really, really useful tools. And like you say, there are a lot of techniques there from motivational interviewing. But again, how much of that is embedded as part of a curriculum, or is it more of a, oh, by the way, this is a thing. Here's a motivational interview, and here's a thing that you can do. But I think that was something that was mentioned in our short form thing as an undergraduate. They said, by the way, motivational interviewing is a thing. You should give it a try. Rather than, okay, let's look at how we support patients who are in distress. How do we support patients who may not be making sense? How do we get genuine behavior change? How do we get people to envision a future when they're maybe not in pain, or maybe when they have rehab from this situation, or maybe when they've taken that step forward and improved their lives? How do we do that? And this is a tool that we can use. And this is what I want you to try and apply to, across clinical settings. So yeah, it's good. It's good. And I think, you know, the reason I'm here is because I think it's a skill that mainstream clinicians can use in their everyday practice. And it's not the hardest thing in the world to be able to empathize with somebody and say, yeah, that must be terrible. How can I help? It's kind of a fundamental of what we should do.
I think some people, I remember doing in my course, and it was interesting because the topic of empathy came up, and it was made clear that some people think that to be able to show empathy and empathize, you need to have gone through what that person has gone through. And I think, and they made it clear that's not the case at all. You can empathize through the active listening, through the way you communicate with them. And it's just showing that person that you are listening, that you understand what they're saying is important to them and so on. And that's empathy. It doesn't mean you have to have suffered. And I think some therapists maybe kind of think, oh my God, this person's going to hell. I don't know what divorce or bereavement or that sort of stuff is. How am I going to help them? You know, and they think they can't show the empathy, whereas really that's not what empathy is about. But I'm interested because I think sometimes you can be born maybe with like I suppose it's a bit of a gift in some cases with this way of communicating, active listening. But other times you do need to be spoon-fed it and learn it and do your homework and practice it and do your, you know, that sort of thing. What was it for you? Have you ever done courses, or did you find that life or experience, or whatever, you were born with it, or naturally you pick these things up along the way?
So it's going to sound quite cliche now, but so for those of you who don't know, I mentioned my brother who has learning disabilities, and it seems almost canon that I would have ended up as a learning disability specialist. That wasn't the plan for physiotherapy. My grand plan originally was to be a solicitor in a law firm, and then until I went on a work placement there and decided that was incredibly boring and involved far too much paperwork. And then I chose physiotherapy because it was active, it was helping people. We'd been through a lot of physiotherapy as kids with my brother and with various friends. I wanted to be a Man United or Leicester Tigers magic sponge physio. And then I went to university, and then I came out of there actually with a real love for amputees and rehab people after, you know, acute injuries. The idea of focusing on the ACL for the rest of my career sounded a bit boring. But I know that those people are needed, however boring they are. Sorry to offend people.
I know, I'm sorry. All the guests I've had talking about the telephone.
The specialists like, oh, patella tendinopathy, really, really interesting. No, it's boring.
Okay, remind me to keep you away from a couple of people at Therapy Expo in November. Mental note.
Yeah, that's fine. I don't want to start any fights. I'm good at dealing with people who are upset. It's okay. We can talk about. But so my childhood and my life was framed around being around people with learning disabilities. And unbeknownst to me, that has Potentially, you bless me, whatever you want to say. I didn't really see it any different from just being life. We went to parties where there were people with disabilities. We were kids' parties, my brother's kids' parties, my brother's school friends' kids' parties, and there were people with disabilities there, and it just was. I might have used this analogy before, so sorry if you've heard it before, but I talk about Christmas traditions. Do you remember, Matt? What Christmas traditions were yours when you were a kid at home? What were some that you've now realised actually are not like ubiquitous Christmas traditions across the board?
Oh, right. Okay. So for me, I think it was being persuaded at a very young age that the reindeers didn't like milk. They actually preferred little glasses of whiskey or brandy. Yeah. That was,
And when was that illusion shattered for you?
I think as I got older and noticed that most evenings my mum and dad were having the same little glasses of brandy and shandy. So yeah.
Fine. So they're probably the great example for that one. But I remember we used to always have porridge on Christmas morning. Mum would make a big pot of porridge, and one of the parents would sit in the presents and they'd pass the presents out. I grew up in a family of 5. It was quite a busy household with dogs, budgerigars, and the whole shebang. And it was only when I went to my first friend's house for Christmas, probably about age 18 or something, and I was like, "You do what in the morning? Bucks Fizz?" And they were like, "Yeah, Bucks Fizz." I was like, "Where's the porridge?" All these things that I'd taken as part of, almost as sacrosanct as having a Christmas tree, as the nativity. It was almost these things are Christmas. What on earth are you doing? You're completely ridiculous. And then it's only at that point when you realize that actually your experience is not the same as everyone else's. And it's only when I got into adulthood and maybe that I realized that growing up around and being around people with disabilities was different. Because as kids, we just accept things as the way they are. Things are presented to us, and that's how things are. And so, growing up with people with disabilities and going to parties and having friends who were disabled people was just normal. And I think that's probably one of the proudest points of my growing up, is it was just normal. But I think what that gave me is a particular skill set around being able to communicate with a wide variety of people. And understanding how people communicate and being able to adapt to my communication style to the needs of that person who's in front of me, whether that's about body language, tone of voice, the complexity of language that I choose to use. And so, I probably do have, that has probably given me more of a skill set that I hadn't realized at the time, and certainly probably wouldn't have been useful had I made it to Manchester United and been the first team physiotherapist. Those skills may not have been quite so well utilized as they are in this job. So yes, I think I probably, to bring it right back round after a long segue, is that I think that it's been part of my upbringing that's helped me to realize these things. And then through clinical practice and 13 years of practice in many different areas, including sports, have led me to sort of realize and reflect that actually, there are things that are useful and that mainstream clinicians, when we look at how clinical practice is going, can learn from. And that's kind of where we're at. So that was kind of nice life reflection there from me. Sorry.
Wonderful. Yeah, Christmas porridge. Yeah, never heard of that one before. Weirdo.
Yeah, exactly. But you don't realise. Well, if I've just had porridge, for those who don't know, but before coming on air, so
I wasn't going to mention that.
No.
So, but it's interesting, because some people do think, people like that Alistair Beverley, he's grown up with all of that, so naturally he's like that. But I have experienced firsthand and seen online as well on in my course that we did with Dr. Gary Mendoza, who sadly he's retiring at the end of this year. But just little things that I remember, which just amazed people, because working in pairs and seeing how you feel when somebody changes something. One of the things, for example, was the intonation, the difference between going up at the end and going down at the end, which I think is quite a classic kind of technique to change something from a question, which is going to demand kind of an answer, to going down at the end, which is more of a reflection and encourages the person just to keep talking rather than thinking, I've got to answer. And just doing this, and even though we knew what was going on when we did this in pair work, you just felt even though you knew it was just role play, your whole body felt different when the person went down at the end of it instead of going up all the time, and even though you knew they were purposely kind of doing one of the many different kinds of reflection and cleverly intertwining these different varieties there, it still had the effect, because we're human, and the beautiful thing is we do react in similar ways to depending on what words are used and that. So it's something which can be learned. It needs to be practiced, because otherwise it just goes away. But for people who are listening, it is something you can do, and it makes a hell of a difference. Amazing difference.
There are a whole host of little subtle tricks that not tricks, tools. We'll call them tools that you can use to help people reflect. And one of them, the easiest one to remember, I find, is tell me more about that. So like there's quite a few that are quite difficult to remember about tone of voice, and sometimes your natural I speak too quickly. I know that, and I need to work on slowing that down, because that gives my words more gravity.
Brilliant.
But my mind runs away with my mouth quite regularly, and I speak quite passionately about the things that I'm interested in, and therefore it runs away. And sometimes I know that that loses the importance of the things that we're saying. But those things are hard to remember, particularly, like I said, if your natural speech tone doesn't always end in a down. Like Bristolian people, they tend to end up at anything at the end, like it's a question, innit? My dad's from that area of the world, so that's not offensive.
You're allowed to do that, yeah. Okay.
yeah. I'm claiming that anyway. But the easiest one to remember is tell me more about that. And because you could have, somebody could have been waffling in a subjective, and you might have been thinking about your clinical reason, and you might have been worried about something else that they've said earlier on, that you're thinking, right, what's my next question I need to ask? And you need a bit more time. Tell me more about that. Or if you've also missed what they've just said and you think, oh, I've missed something really important, just tell me more about that. That's a really, really useful tool that you can use. The other thing is repeating the last few words that the person said. It's another way of saying, tell me more about that. It's a natural way that will get somebody to continue to speak a little bit more. And I think I was listening to, who was it? It was Rob. Back in podcast. He said he uses it quite a lot, and he says he uses it. Yes, he uses it with his wife as well. And he said, if I'm not paying attention, I'll just repeat back the last few words of what they said, and people just carry on. People just carry on.
To this now.
I did say
how many downloaders we've got. You just ruined his marriage.
Sorry, yeah. No, he said it on his own podcast first, so I feel all right.
No, it's okay.
We're just amplifying his message that he's a bad husband, don't we? That's all.
Rob Bevan, sorry about that. He did warn me about.
Love you, Rob. Love you, Rob.
Yeah. No, it's true. It's excellent, and the pause, of course, and that feels really alien sometimes, where you just don't talk, and even just put your hands over your mouth, because you want to solve it, don't you? You want to give them the answer. You want to unleash all these solutions you've got to their problem, and you mustn't. You got to kind of just look at them, and then I love the idea. And again, this is kind of stuff which I really appreciated, where the first time someone talks, the first sentence or two is maybe telling you what they think you want to hear, and that. But every time you pause, and then you start peeling off the layers, and then eventually the next thing they say is a little bit more from their memory, or a little bit more truthful. And then the deeper you get, the more they're actually telling you stuff which they're not just presenting it to you like, here's the first layer. It's you get to know, listen to them enough, and they'll tell you how to fix them, kind of stuff. Listen some more and all that sort of stuff. So yeah, amazing. We haven't given away too much about what you're going to be doing in the presentation at the STA Theatre. I'm worried here that you've already handed out all of your kind of tools now. You've got some stuff.
Yeah. Damn it! You're not gonna need me anymore now, are you?
Well, it'll be interesting, because it is an open air. Well, obviously you know what it's like, but it's an open air theatre, which means that you can get as interactive as you want with people, and they'll all be sitting around you in a horseshoe, kind of looking up at you, the guru that you are. So it's a really nice opportunity. I mean, the other big theatres are great as well, which like last year in one of the big theatres, 120 people. But I think sometimes with things like this, well, to teach communication, hey, let's get people communicating. It's quite a good way to learn it, isn't it, yourself? So that'll be interesting.
Exactly. I think it's really useful to get some interactive element, and hopefully that's something that it is something that I want to be part of the talk. Obviously, it's a small time frame, so it's trying to keep things succinct and maybe trying to punch at the take-home messages. But yeah, practice is certainly important, and I think that's a really big point. Just to help people to understand the impact of it. And like you say, when you practice it yourself, even knowing that you're practicing it it can have quite a profound effect on how you
Mm.
feel in that situation.
Definitely. It's interesting. I wonder whether, because we started off saying like you're in a very kind of niche population and you've tried kind of changing that by the NHS and has some success, but I wonder by teaching therapists about the parallels and how you can take some of these techniques aren't just for this population, they actually work for your population too, then actually therapists will twig that, hold on, maybe these people who he works with, who I thought were just like another world of people who are nothing that's similar to my clients, are actually very similar and we're using the same technique. So do you think there's a kind of reverse thing where it will raise awareness and get, kind of break down that wall of the smiley Down syndrome boy who's such an angel and walks down the street and everyone goes, oh, isn't he lovely? They're very friendly. They love hugging. They love hugging these people, which I know you hate.
Oh, man.
Will it help get rid of some of those kind of stereotypes, which is what, really holds things back in terms of understanding people with learning or intellectual disabilities?
Yeah, no, I certainly think it will. And we need to remember that people with learning and intellectual disabilities make up 3% of the population. It's about 1.4 to 1.5 million people in the UK. And people with learning disabilities get back pain. People with learning disabilities play sport. People with learning disabilities have Achilles tendons. They have patellofemoral tendinopathy, if we're going to plug that one again, tick it off. They'll have, bucket handle tears and meniscus. Particularly people with Down syndrome who are more prone to being hypermobile. If anything, we see an increased frequency of those. But why aren't the specialists in bucket handle meniscus tears seeing these people? Why do they come to me? And actually, my mantra is that, when you pass them to me, you're passing them to a lower standard of healthcare because I'm not the specialist in that. I'm a bit of a specialist generalist. And we do need myth busting. There was a report that's just been released by Dimensions, who are a UK charity supporting people with learning and intellectual disabilities, on societal attitudes towards people with learning disabilities. And hate crime is up 25% in the last 2 years. So hate crime has risen by a quarter. 6% of the people that they surveyed, and they surveyed 2,000 people, said that they had committed physical violence towards somebody with a learning disability. And that their learning disability was the sole reason for them committed violence. People under 35, a significant proportion had said that they had laughed or engaged in online trolling or found videos where people with learning disabilities were being poked fun at. They found them funny. And, there's a fine line between what is somebody with a learning disability being funny and somebody with a learning disability being made fun of. Mm-hmm. There are some great creators out there who make some fantastic content for the purposes of being funny and performing. If you look for some, there's a couple called the Brotherbies, who are some Australian lads. They're two brothers, and they are hilarious. There's an Irish comedian called Fionathan. Search these people up. They are very funny, and they are there for the purposes of comedy and being funny. But when people are poked fun at, that's a very different thing. So I was reading this report that came out from the research. It was published in the Huffington Post, a bit of a summary. This is on top of a MenCat report that said that 9 out of 10 people with learning disabilities have been victims of hate crime in the past, and those rates continue to rise. So we need some myth busting. We need to realize that, not everyone with Down syndrome is going to be smiling, and somebody might be a powerlifter and might take your head off. My brother, strong as an ox. And I always say that people with learning disabilities have the right to be a dick. That was my brother had the right to be a dick. And he was a dick sometimes because he's your brother. So, we need to dispel these myths that, people are all angels sent from heaven. It's nonsense. People are people. People have healthcare needs, and those healthcare needs should be met by the best people, the experts in those areas. And if those experts need a bit of help to support that person, then we're happy to do that. But they should be seen by the experts. And if not, then actually you're accepting that they deserve a lower standard of healthcare. Mm-hmm. There's a reason that learning disability is written as cause of death on a lot of people's death certificates. And that's because it demonstrates a lack of poor understanding about what a learning disability is, because a learning disability is a difficulty taking on new information. people don't die from that.
Mm-hmm.
People die from poor healthcare that's associated with attitudes towards people who have those conditions. And, we can't be so sanctimonious to think that we as healthcare practitioners are not represented within those 2,000 people that were surveyed in that. We can't think that, there won't be a proportion of people who will have engaged in those things online. We're not better. We are a population, and we are the public. So, coming full circle right back to the diagnostic overshadowing, if we can make ourselves more aware of our own biases, then we can look to treat people better and provide people with better healthcare.
Amazing. Great. Well, look, time is there. Definitely, it's going to be really interesting that people now can draw that parallel between the work you do and how what you have to do can help so much when working with, I don't like saying normal population, the more common population. Because there are so many parallels, and that's because the people you work with are people as well. They get angry and they can be helped in the same way. So some amazing parallels there, which hopefully listeners will understand and take on. And if you have been listening and you are going to the NEC Birmingham in November on the 22nd and 3rd, then my guest tonight, Alistair Beverley, ldphysio.com, is going to be on day 2, so the Thursday, in the STA Update Theatre at 12:15 p.m. And if you do want to follow Alistair before then, find some more out. I'm going to just bring up your website because there's so much information on there. So let me just put that on the screen. So the ldphysio.com, very easy to remember. If you go there, there's a wealth of information, and I would encourage you to read the blog. If anything, just because of the talent this guy's got in writing. Obviously, the subject matter is so important and valued, but the humor that you use, and I've said this to you before in the last one, is it's so engaging, it's so readable. And like we said before, there are stories of John, your brother, and you growing up, and some of it is literally it's so beautifully written, so humorous. But it really gets the point across that people with learning disabilities, yes, they have learning or intellectual disabilities, but they're people as well, and they can get depression, they can get angry. They, if anything, well, we know they do have more tendency towards getting mental health problems because of the worlds they have to live in, and unfortunately because of us a lot of the time, because of us smiling at them and just nodding and then ignoring them. So it'll be a real education experience, people, if you go to that, the ldphysio.com, and then also follow Alistair on social media as well. Loads of content. I don't know how he manages to do it, but if you follow on either Twitter at the ldphysio, Instagram at _ the ldphysio _ then yes, you will learn a lot, and it'll be a very pleasant, as he preaches, a fun way of learning, which is the best way to learn. So there we go. Right. Thank you so much, Alistair, for your time once again.
Thank you.
It's been great, really informative. Really looking forward to catching up with you in like less than 3 weeks now, mate. Amazing.
I know, can't wait.
Yes,
thanks so much, Matt. Thank you very much for
wonderful.
listening, and have a nice evening.
Mas, thank you very much. If you can hang around, I'm just going to shut down the live lounge. People, if you have been joining us live, then thank you very much. No questions tonight, but I guess that was because you were listening and just jaw dropped and taking notes down. If you do listen to the podcast, or to the many people who do download the podcast, then thank you very much. If you could just leave a rating or a review, as long as it's good, obviously. Don't bother if you didn't like it. If you did like it, then rather than just giving us a kind of like a metaphorical pat on the back, actually do something useful, which is chucking down 5 stars and a comment, because that just helps the podcast appear higher up. So if someone does put in learning disability, then bam, in Google, it will be our guest here, Alistair, talking about it with such wisdom. So do please, don't think everyone else does it, because they don't. We've got about, 5,000 people in the Sports Therapy Association, and we've only got about 30 likes. So something's gone wrong there. The math is not working. So please do that. If you want to join us next week, then that's great. We'll be back on the Tuesday, which is the 7th of November. And in next week's episode, which will be 173, then myself, Gary Benson, and special guest Andy Hosgood of Elevate Your Clinic are going to be having a whole hour devoted to how to make sure Therapy Expo helps your business. Okay, we know that there are some exceptional speakers like Alistair coming along in November. You will be sport for choice. There will be too much for you to absorb, and we don't want you running around getting stressed out and not taking any information in. So we're going to try and give you some tips of how to make sure that you don't just wake up on Monday thinking, what happened there? 2 days and I can't remember a thing. and you just go back to doing what you did before, because that's a waste of your money, and it's not going to help your clients. So we'll be devoting the hour to that. So if you'd like to join us, then just go along to the Sports Therapy Association YouTube channel, or we'll also put it out on Facebook as well, depending on which you prefer to watch. So once again, thank you to my guest Alistair Beverley, and thank you to everyone else. Take care of each other.